Inside the microscopic truth, why is pathologist considered to be the most important part of cancer story?
Pathologists are always behind that phase. So whatever the doctor decides for a patient is always what is actually given by the pathologist.
Right.
So pathologists, we were just talking about stories. So pathologists write not only the stories, but they also write the present and also the future.
Very nice. So they're doctors, doctor.
Yes, absolutely.
Very nice.
Yeah.
The importance of pathology, specifically in oncology, it makes much more difference because it's not just the diagnosis, it's also the risk classification, and the whole treatment paradigm can change based upon your reporting.
Welcome to Oncoflix podcast. I'm Dr. Lohit Reddy, consultant radiation oncologist at HCG Hospitals.
And I'm Dr. Kritika, consultant radiation oncologist at HCG.
Inside the microscopic truth, today we have with us a renowned pathologist from HCG Hospitals. She is the head of pathology department, and we welcome Dr. Veena Ramaswamy. Welcome, ma'am. Welcome to our show.
Thank you, Dr. Limit. Thank you, Dr. Kritika.
Why is pathologist considered to be the most important part of cancer story?
Okay. So it's not just a cancer story. Pathologist is important in every diagnosis that a patient gets, right? So the patients usually know only the doctors they meet as a part of their treatment protocols. It's only the face that they see.
Correct.
Pathologists are always behind that face. So whatever the doctor decides for a patient is always what is actually given by the pathologist.
Right.
So pathologists are always at the back end, and they do a lot of work to arrive at a diagnosis that actually helps the patient in further management. So pathologists, we were just talking about stories. So pathologists write not only the stories, but they also write the present and also the future.
Very nice. So they're doctors, doctor.
Yes,
Very
absolutely.
nice.
Yeah.
Interesting.
So, back screen hero,
Yes.
to call it rightly. Madam, we know that the importance of pathology, specifically in oncology, it makes much more difference because it's not just the diagnosis, it's also the risk classification, and the whole treatment paradigm can change based upon your reporting. How do you see the effectiveness of present pathology training? Let's say somebody has finished their MD pathology. How competent are they to report an oncopathology or a cancer patient's report?
Okay, so this is an interesting question. So, way back, say 20 years ago, when we were trained, it was all a hard learning. We didn't have much technology. We didn't have, the tools that we have today to learn. So, everything was a hard learned. So, we had to put in a lot of efforts to learn what it is, and then the material also was very limited. So we had to put in a lot of efforts, learn from our seniors, learn from our the teachers. I have a regular teaching program. So there was a huge interaction between the student and the teacher, and the teachers were also very happy to pass on their learnings to the students. But if you look at the current generation, it's all technology driven. So they have everything at the tip of their fingers. So it's not that they have to put in any efforts to learn anything. Everything is easily available for them. And in that process, I feel they are losing their knowledge of basic understanding of what pathology is, and then whatever they learn is all from the books or from the internet, and that they try to bring it in their clinical practice or in their practice of pathology. So I think that is where the fresh pass outs actually would not be the right people to write a diagnosis of cancer. They still need a lot of training, orientation, particularly with the clinical practice. So pathology is not just something that we see under a microscope. It requires a lot of clinical correlation, radiology correlation. So this is something that the current generation lacks. So it's yeah.
So it needs a specific training itself after their pathology or during their pathology to even be able to report
Yes,
a single case of cancer.
absolutely, yeah.
And what exactly is a biopsy and why is it considered the gold standard, especially for cancer diagnosis?
Yeah. So clinical examination conducted by a clinician basically looks at the physical appearance of the particular lesion. The radiologist sees shadows. I would not we calling it as shadows, certain appearances of an image. So which can be a benign, can be inflammatory, or can also be malignant. So a biopsy is a procedure where we just take out a sample from that particular lesion, and then we subject it to various stages of processing, and then we make slides to see it under a microscope. So we know the normal structure, and then whatever we see under the microscope, we try to correlate whether it mimics a normal or it's abnormal. So if it is abnormal, what type of abnormality is something that we sign out. So that is where biopsy plays a very important role, because that is a sample from the lesion that is studied under a microscope, and that writes the future for the patient.
So, how important are the steps that are done post biopsy? Let's say preparation for you to read the report. How important is that step? Is it possible that a good sample, badly handled, may lead to a bad report?
Yeah, that's a very challenging and an important question. So let's take the example of breast cancer. So today, when we diagnose a breast cancer, it does not just end with the diagnosis of cancer. There are so many other things that we need to do, because we need to look at the expression of hormone markers, what we call as breast biomarkers, because the treatment depends on the expression of these markers. So if you have to write down an accurate diagnosis for the patient and also an accurate treatment option for the patient, initial handling of the sample is very important. So we have what is called, like, once we take out the sample from the body, it loses all its connection. So the blood supply is lost, and then the connection to the normal structure is all lost. So in that process, it undergoes what we call as a sort of autolysis. That means the cells die. Okay. So if we don't preserve them in their normal state, then whatever we see under the microscope will not be a mimicker of what we see.
Okay.
So that is why handling of the tissue soon after the biopsy is very important. So there is what is called as a cold ischemia time. So that is the time period during which the tissue is safe. After that, it starts deteriorating. It undergoes autolysis. So the maximum time that we can allow a biopsy not to be put into a fixative is around 45 minutes. So once it is out of the body, it's always better to put it in a fixative. Okay, so there are so many fixatives that people have experimented since ages, and all these years we were using 10% formalin as an ideal fixative. So the function of this fixative is that it preserves the tissue in its near normal state.
Okay.
Okay, by fixing all the proteins around it, and then it preserves in its normal state. But what happened with the advent of all these new technologies and the availability of therapies? So we had to identify certain fixatives which are good for performing all these newer technologies. So that is where 10% neutral buffered formalin was found to be the ideal fixative that not only preserves the tissue in its normal state, but also enhances your biomarker testing, the genetic testing, molecular diagnostic assays, etc. So today also we get many tissue samples or paraffin blocks that have been fixed in 10% formalin, and we really struggle to look at the marker
That was my next
expression.
question. That in oncology practice, our first step is always to confirm the diagnosis.
Yes.
If we do the biopsy, it's different. When they come with an outside biopsy report also, we always tend to review the slide or the tissue of biopsy and confirm it. So how they have processed it is going to make a difference in your reporting also. So this is a very important point.
Yes, huge important. I mean, it's very important, because even in our day-to-day practice, we see so much of difference. What has been called outside as ERPR positive, or negative, turns out to be positive when we repeat it in our
and that makes a huge difference in treatment.
Yes. Handling of the tissue, what we call as the pre-analytical factors, are very, very important.
Right.
So how does a pathologist know if the cell is cancerous? What are you looking at in the microscope?
So we know the normal human anatomy and the histology. Histology is like how the cell normally looks and what is its relation to its surrounding structures or the surrounding cells. So the same thing we try to look under the microscope. So we have been trained in our, the curriculum that this is how a normal cell looks, and anything that deviates from a normal cell is something abnormal. And this abnormality we have to categorize based on not only the cell itself, but also based on its surrounding. So whether it's this abnormality is because of some infection, or whether it's a regenerative process by the cell due to some injury, or it's a pre-malignant lesion, or it's really a malignant lesion. So the comparison is always between a normal cell and an abnormal cell, and then subclassifying that abnormal cell into different categories. Yeah.
So, madam, considering the fact that not many hospitals that operate have a in-house pathology lab, and for us as radiation oncologists, it becomes very important they mark the area where they have operated, what we call as clipping. Similarly, for you to comment whether they have removed it completely, they should have marked the orientation of the specimen, which side is what, and all that. So, how do you look at it? Having an in-house pathology, that to oncopathology for reporting, versus some surgeon in some ex-hospital operates and sends it to a Y pathology lab. They have no information about the surgery or the surgeon. They have to report that. So, how do you see this?
Pathology reporting, as I said earlier, has to be, a dialogue between the surgeon and the pathologist. So the surgeon has to, because surgeon is the person who is handling the patient, and he knows the anatomical orientation
Right.
of what he's taking out. So it's very important that he marks out what is superior in relation to the patient's orientation, what is superior, inferior, medial, lateral, etc. Because what comes to us is only that tissue. So, and we will not be able to orient that, in the anatomical position. So if a specimen comes without any label to us, so we are clueless what we are, which one should we process as which. So if some margin turns out to be positive, how is that going to impact on the patient management? So if I assume that probably this is an anatomical orientation, and I call something as superior, and I say superior margin is positive, but finally the surgeon feels that it's inferior margin, while operating he felt probably that was the closest, probably that's the inferior margin, but he's not sure. So it totally changes the patient's treatment, and particularly from your radiation point of view. So where do you target, and what do you target, and then so which margin, if at all he has to revise, where will he go and revise it again? So that's another challenge. So it ends up, patient again ends up in doing a wider resection, and then so again unnecessary surgery for the patient. So it's always better to have a proper dialogue between the pathologist and the clinician, and then mark out whatever they are doing, at least with clips, or even with certain suture materials. So I think so that way, I mean, some good surgeons have the habit of drawing a diagram also. That gives a lot of information to the pathologist in relation to the orienting to the patient, and then identifying this is superior, this is inferior.
Right.
And in such cases, whenever we have a doubt, we usually call him and then say that this is the concern that we have. So that way it becomes very easy. It's very helpful for the patient if the surgeon and the pathologist talk to each other, and then
Right. So, from a common man perspective, when somebody has a lump or some issue which is going to require a diagnosis or not of cancer, it is always better they get it done at a center where there is this dialogue between the surgeon and the pathologist.
Yes.
So there have been clinical scenarios where, for example, when you take breast lump, okay, they go to a surgeon, he suggests for an imaging, they do an imaging, and then they come to you for a biopsy. And, in the image, it's suggestive of cancer, okay, 99% probability. And then when they come to you, you do a biopsy, you evaluate under your microscope, that turns out to be negative. How do you manage these kind of situations? Does it happen often in your clinical practice?
If it is done in centers like HCG, doesn't happen so often, because we have expert radiologists and the pathologists also who practice subspecialty reporting. So it doesn't happen that often. But if you get it done in some other local hospitals who do not have such expertise, so it often ends up in getting a wrong diagnosis. Probably the radiologist is correct. The biopsy may not be representative, or the pathologist interpreting may not be trained enough to identify that. So there are multiple, challenges that can happen if it is done in a center which is where they are not equipped or do not have that expertise to handle such cases.
Okay.
Yeah. But in our center, we don't see such
Discrepancies.
challenges, discrepancies. And we also frequently talk to our radiologists whenever we have such situations.
Right.
We talk to the clinicians, we talk to the radiologists and tell them that this is what we are seeing. So this is what the radiologist says, this is what I feel. Then we discuss whether if there are any other differentials and whether they have really targeted the lesion.
Correct.
If everything is okay, and then we still prefer to do another biopsy if possible, we do it. Otherwise, wherever it is not recommended, probably the patients would go on a
Correct.
follow-up and then, yeah.
I have to quote this case. She was a very young female, 30 plus. So outside, she was evaluated for a thyroid swelling and it was labeled as medullary carcinoma. Somebody we have recently seen. So they came to us, we did the repeat evaluation because we were not fully convinced. And you rightly reported it as thyroiditis, active thyroiditis that was happening, and there was no
Yes,
proof of malignancy. In fact, we did a PET CT to make sure everything was okay, and we really didn't miss any spot that was ongoing. So this patient was in extreme happiness and tears once they got to know the right diagnosis. Although we got the credit for it as back screen heroes, I think the whole credit goes to them. The importance of labeling a cancer as cancer
Is absolutely.
Yeah.
is as much important as
Yeah.
labeling
Yeah.
or not cancer
Not
also.
cancers,
Yeah.
Yeah, I think that is much more happier for the patients,
Right.
than getting a diagnosis.
Yes, more often we have seen a lot of cases, at least a handful of cases where they've been detected as cancer outside. We've done all the reviews, made sure meticulously none of the facts were missed and proved that it wasn't cancer actually.
Yeah. We do follow up this, we have a practice in our lab where whenever we get a review case, then we report, and then on a periodic basis, every month we tabulate and see what has been the outside diagnosis, what has been our diagnosis, then clinical correlation, radiology correlation, and it's almost like 35 to 40% of discrepancies is what
Correct.
we have
35
observed.
to 40%. That's
40% of
huge.
discrepancies. Benign being called as malignant, malignant being called as benign, and then changes in the histological types of tumors, the extent of tumors, margin status, presence of LVI, PNI being missed out. So it's a huge.
So would you
discordance,
label all of this on the expertise, or is it because of the processing or the radiologist? How do you see it?
I think it's all related to the expertise.
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 So that's where, as it even we say that at MBBS level, we never get exposed to oncology
Yeah.
training as much. Even if we do, it may be hardly for a couple of weeks where you don't even understand what is happening. So if that being so, with pathology being the back screen heroes, the complete management is dependent on your reporting.
Yeah.
I think that bit of training before they even get to report the first case is
Yeah.
very important.
Yeah, correct.
It is a lot of pressure as well, because you're the one who is going to decide the fate of a person's cancer diagnosis, to what treatment to be given as well, because based on histopathology itself, we as oncologists will decide on the treatment paradigm and the final outcome based on your pathology as well. So, ma'am, coming to the advances in pathology, we're talking about next generation sequencing, the proteomics, the metabolomics as well. How are you incorporating all these advances into your clinical domain?
Pathology has evolved over centuries, so I can, quote like the classification of pathology, different pathologies probably started about 75 years ago. So where, if you look at the initial AFIP classifications, there used to be only two tumors, a benign and a malignant. And then slowly things started evolving, the looking at the different morphologies of the tumor, and then, the different protein expressions. So things started getting much more, clearer and clearer, and many more entities have now come into the classification. So if I can quote an example of, say, renal cell carcinoma, way back in, I think the classification started way back in 1975, when it was just a renal cell adenoma and an adenocarcinoma. That was the two AFIP classification. But today, in the year 2022, we have 21 different histological types of renal cell carcinomas. So some are based on the morphology, and then even when they did the morphological classification, they started noticing that why the patients with similar morphologies do not behave the same way. right? So that is where the molecular studies came into picture, and then they started identifying that though morphologically they are similar, but at a molecular level, genetic level, they are different. So they have certain driver things, driver mutations or certain genetic signatures that makes them different. So that is where now we are moving into the molecular classifications of tumors. So, yeah. So morpho and molecular classification. So like a clear cell carcinoma of the kidney need not always have a VHL thing. So it can also have many other genetic signatures. So depending on those, the patient's behavior, the clinical outcomes, the treatment options, all those actually changes. So that is where the molecular signatures are playing a very important role in the treatment, is not only in the classification, but also in the treatment choices, prognostication, and also with the follow-up of the patient.
Today cancer of the uterus is completely driven molecularly for the treatment.
Yeah, so we have kidney, we have bladder, we have breast. I mean, the molecular classification has been there for many years. Endometrial cancers. Now we are going to come up with many more other molecular classifications. And even morphologically also, sometimes it's little difficult. You may, even when you look at the IHC signatures, there will be, like, for example, if you take a sarcoma. So there are many sarcomas which express CD99, many sarcomas which express like SMA and some common markers. So just because it expresses CD99, I cannot call it as an Ewing's, or I cannot call it as a synovial sarcoma. So I need to have further genetic workup for the case. So that is where these molecular studies have really helped in the diagnosis and also in the prognostication of these patients. Yeah.
So from a common man perspective, let's say a biopsy is done. For some of the tumors, we are able to get the report in 2 days. For some of them, we get a report saying that additional testing such as IHC, immunohistochemistry is required, where the report may be delayed by a week or so. So what is immunohistochemistry? How important is that from a pathologist perspective?
Yeah. So as we were just discussing about the morphological appearances of the tumor, if we have to look at the protein expressions of the tumor, so we use a technology called immunohistochemistry. So every cell has something unique to it, what we call as antigens. And so we use antibodies which actually go and bind to that particular cell. So based on the antigen antibody reaction, we actually use a colored substance which will bind to this antigen antibody signals, and then we look for those colored signatures under a microscope, and then based on the presence of that color we say whether it's positive or negative. So the basic principle of immunohistochemistry is nothing but an antigen antibody reaction, and every cell in our body has a specific protein expression. For example, if you take thyroid, it has a specific marker like thyroglobulin. If you take lung, it has TTF1 expression. If you take breast, GATA3 expression. If you take gallbladder, it has MUC1 protein expression. So using these different antibodies, which are specific to these different sites, we will be able to perform this immunohistochemistry test and come to an accurate diagnosis. Not only the diagnosis, but certain of these markers can also help in the treatment choices. For example, HER2 positive breast cancers, hormone positive breast cancers, and similarly MSIs, PDL1s, immunotherapy choices. So they all help in the treatment choices, and they also help in the prognostication of the patient. Yeah,
Immunohistochemistry from a common man perspective, it helps in diagnosis a blanket tumor which looks the same, to deblanket it and find out exactly where it has come from, and it also helps in detailing.
Correct.
Which may be related to how well they may do, or for the treatment perspective itself. And in cases where that is required, the report gets little delayed than the common ones.
Ma'am, can a blood test ever replace a biopsy in detecting cancer?
Biopsy has always been the gold standard, but there are situations where it's not possible to do the biopsy. So in such situations, we have a technology called liquid biopsy, wherein the cancer cells, we can make an attempt to look for the presence of the cancer cells in the blood sample. But a invasive tissue biopsy has always been the gold standard.
Gold standard. But in future, with development of technology, that could also be a possibility as well.
So let's say a person is going and getting operated somewhere, and they get a report of malignancy or no malignancy. What advice would you give to them to know that the report is reliable?
Okay. I can quote a couple of situations. As I was telling, 35 to 40% of differences that we see. So you can quote a couple of situations. One was a 32-year-old woman in one of the reputed hospitals outside, diagnosed as carcinoma of the breast, and she came to our hospital, and it was all full panic. And then you can understand the impact of cancer diagnosis. So then we got the slides for review, and we were not convinced, that we felt this was not cancer. And so we spoke to that pathologist, and she said she believes it is cancer. So we had to do immunohistochemistry to prove that it is not cancer. So we did immunohistochemistry, and we said this is not cancer. Okay, and then the surgeon still wanted to assure the patient and then also confirm it. So he went ahead and did a wide local excision, and finally it turned out to be benign. So it was such a relief for the patient. So certain and we also have another situation, and again this was from another reputed hospital, some a nasopharyngeal mass which was reported as multiple myeloma. Okay, so this patient happened to have a tooth extraction, and following which he started developing pus discharge, and it was not stopping. There was a lot of smell, and then that is when he went to the dentist. So the dentist did an OPG, and he saw some lytic lesion there, and he just curated it and just sent it to a lab for diagnosis. The lab called it query multiple myeloma. Okay, and then it went to another reputed lab in Mumbai. They did a lot of workup, immunohistochemistry, everything, and they called it a confirmatory of multiple myeloma. This is again a young chap, 35 years of age. And so then he, only son of the family, and then elderly parents, only earning member of the family. So he came with his parents, all with the parents were in full tears, and then you can understand the impact of the cancer diagnosis. And then so the biopsy was sent, the slides were sent to us for review. We reviewed, and there were sheets of plasma cells. I mean, anybody could blindly say that it is plasma cell rich lesion. But when we did a further evaluation, we did immunohistochemistry, we correlated with our, the radiology, the clinician, we spoke to the clinicians, we spoke to the patient himself who walked in. He was very worried. So we took a complete history. And then finally, when we did an immunohistochemistry, it just turned out to be a plasma cell granuloma, which is a very benign condition. So they were so relieved, and such things do happen when things are handled by people who are experienced but still do not correlate with clinical and other findings, and can also happen in people who are in reputed centers but not doing a pure oncology work.
Right. That's very important. Going to a place which has enough experience in cancer detection makes all the difference.
How long does it usually take for a biopsy report to be out?
So if there are multiple types of biopsies, so one is just what we call as, we do under the radiology guidance, like true cut biopsy or a needle biopsy, where core needle biopsy, whatever. So that processing of the biopsy is very important, because we have to preserve the tissue in its near normal state, ensuring that it retains further processing, staining and all. So that process itself takes about 12 hours. So we have a overnight schedule. So wherein the tissue is subjected to different grades of alcohol, xylene, embedded in paraffin. So that entire process takes about 12 hours. And then we have another 4-5 hours for our slide making, embedding the tissue, making trimming, making the slide, and then doing the staining and submission. So if you ask me, orally a pathologist can give you a report in 24 hours. 24 hours. And then the final, typed report, and if it is a little difficult case, do a little bit of research, and then talk to your peers, take their opinions. So that may add another day or two. So ideally you can keep it as 48 hours for a small biopsy to be released to the patient. But if you have resections, like radical resections, where extensive sampling of the tissue has to be done, so like minimum we take is around 25 blocks from such specimens.
Okay.
Yeah, and prostate to minimum is 100 slides what we make. Okay, so that will take at least about 6 to 7 days.
6 to 7 days.
Yeah.
So you spoke about discussing with your peers. So do you have any subjectivity when you decide on the reports between your peers as well? is there going to be a difference of opinion when you discuss with another pathologist in your same lab in deciding the accurate diagnosis? Has that happened in your clinical practice?
Yes, this usually happens with lymphomas.
Wow.
Yeah, that's see, not all large cells lymphomas are Hodgkin's. So you do have certain entities where you still see large cells, but they are non-Hodgkin's lymphomas.
Okay.
So the such discussion usually, such subjectivity usually happens with lymphomas, but now with the extensive panel of immunohistochemistry, that is taken care.
Perfect.
But we are open, we don't get biased. We talk, we discuss, and then what could be the differentials, what is my first diagnosis, second diagnosis, what is the other person's. We are 5 people, so we all discuss together, and then accordingly we plan, and then because it's all in the interest of the patient, so no egos here, so it's primarily the patient. The priority.
So, as much as importance for the pathologist in diagnosing and prognosticating cancer, so much is in research also. In fact, I think there is no research that we do today that doesn't have pathological detail in it or classification. So, what exactly is this tumor microenvironment?
If I can give the simple example of a plant, right? So if you look at a plant, so what we see is just what is here, but for a plant to grow, you need oxygen, you need water, you need a soil, and then you need to have a pot, so tumor microenvironment is something like that. So your tumor is like a plant, and the all this oxygen, water, the soil, the pot, everything that supports the growth of a plant is a environment that actually is either, it may be either supportive to the tumor, or it may also have certain factors which are adverse to the tumor. So whatever is around the tumor, inside the tumor, supporting the growth of the tumor is what we call as microenvironment. So this may have certain cells which actually support the tumor growth, or some which suppress the tumor growth, and it may also have certain what we call as substances which support the tumor growth, or they may also be deleterious to the tumor. So if when we talk about the cells, they may be immune cells, what we call as immune cells, which are your own body's, what we call as policemen in your body. So they are like your own cells which fight against anything. It may be an infection or a cancer. So they fight against it and try to protect you. So these are the immune cells. And there are certain other cells, what we call as stromal cells. So we have fibroblasts which produce the matrix, and then we also have vascular endothelial cells. We have nerve cells, that also play a very significant role in all this. So the entire complex, which are within the tumor and supporting the tumor, forming that entire niche, is what is called as the microenvironment. And all these years, the focus has always been on the tumor, because everybody wanted to, we thought that it's only the tumor that's growing, and so we need to target it. But the focus is now taking into consideration the microenvironment also, because unless you, cut whatever is
Correct.
supporting to the tumor growth, the tumor, it will not be possible to handle only with the tumor. So it's a concept that is well developed now, and but again, still some research is going on. But as far as immune cells are concerned, we have a lot of information now available, and the treatment strategies have also been designed on.
So, based on the information that you gave, let's say a patient is undergoing 4 cycles of chemotherapy.
Yeah.
A biopsy was done upfront, and let's say after 2 cycles, a repeat biopsy is done. Is it possible for you to say whether the patient is responding or not based on the features that you mentioned?
Yes.
It is possible.
Yes, it is possible. It is possible. So when we look, as I was saying, our body has immune cells. So based on the amount of immune cells that the tumor has, we categorize them as hot and cold tumors. Like abundant immune cells, we call them as hot, and then less immune cells, we call them as cold. So when we do an initial biopsy, it may be a cold tumor or it may be a hot tumor. So when a repeat biopsy is done, and if there is a good response to therapy, the percentage of these immune cells may vary. And also there are certain other changes that the stroma undergoes. There will be death of cell, which we see as necrosis. Okay, and there may be fibrosis. All the dead cells will be replaced by the fibrotic stroma that may be there. And there may be these scavenger cells like macrophages who come into that picture, and then they start engulfing all these, and they become laden with hemosiderin. So we may see a lot of hemosiderin laden macrophages. So all these are indicators of therapy responses. We may start seeing some specks of calcification as a response to therapy. All dead cells have to be finally removed, so specks of calcification will appear. So all these changes we can see, and based on the percentage of the response, we can either say they are responding or they are not responded. Uh, Even immune cell concentration can also vary. If a hot tumor can become a cold tumor if the response has not been that good, and a cold tumor can turn to a hot tumor if the response has been good, depending on the treatments.
What is this frozen section and how many hospitals have this facility?
So the frozen section is a very sophisticated advanced technology. So what happens is the patient is on the operation theater table. The surgeon wants to know what the extent of surgery that he has done, whether it's adequate or not. And then sometimes he may want to know the diagnosis as well, because probably in the, before the pre-operative work, probably he would not have got a diagnosis, or there has been daisy situation where he's not able to decide whether it's benign or malignant. So he takes out the tissue and sends it to the lab. So this technology actually requires the skill set. It also requires a sophisticated equipment called a cryostat. So what happens is, once the tissue is received in the lab, it is immediately snap frozen. So we freeze the tissue at minus 25 degrees, 25 to 28 degrees, minus 25 to 28 degrees, and then we make sections from that. So in 10 to 15 minutes, the tissue is frozen, and then we take sections, and probably in about 20-25 minutes, the slides are ready. The pathologist can have a look at it and call the surgeon in the OT, saying what is the clearance, whether it's adequate or not, whether he needs to revise the margin or not, and if he's looking for a diagnosis, this is the diagnosis.
Right.
So based on which he can decide whether he needs to close or whether he needs to
Extend
extend
the
the
very
surgery.
important point. In fact, they say the report is variable, be it breast or sarcomas. Roughly 40% of excisions or removal of a lump or mass or tumor done outside is unplanned.
Yes.
So if they don't know whether it is cancer or not cancer, they go operate,
Yeah.
then they wait for the report and they find out that it is cancer, then the whole cycle starts. Rather,
Yeah.
when they come to a center of expertise, this is what happens.
Yeah.
Even if there is a doubt, you have this access where a report that usually comes in 3 to 7 days, you get the report in 30 minutes when the patient is still on the OT table, which means you don't need a second surgery in the same sitting. If a more extensive surgery is required, if it is going to be a cancer, that
Yeah.
can be done.
Yes.
So this becomes a very, very important tool in managing tumors that are doubtful and even for adequate
Yeah.
removal of the tumors.
Yes. And it requires a skill. As I
Yeah.
said, it's a skill set, and the pathologist has to be trained on it, because it's not, the tissue doesn't look like what we see on a biopsy.
Right.
This will have a different appearance.
So they need special
Yes,
training to be
training for
able
that,
to
yes.
report a frozen section.
Yes.
So we always envision a pathologist to be, with a microscope. Okay. But now with digital pathology coming in, is there a possibility of you reporting and seeing slides on your tab and reporting on your tab? Does that happen in your department?
Yes, it does happen. Yeah, I think, digital pathology started way back in 1985, and pathologists have not been that open, because radiologists adopted it very soon. But pathologists have not been that open because of several challenges, technical challenges, because the size of the image itself was so huge, the internet accessibility, the training required, and accessibility to the technology itself were all limited. In 2016, the FDA gave approval for the digital pathology scanners to be used in the clinical practice. So that is when the people
Adaptation.
started adopting to it. I mean, it's still not completely adopted. I mean, they started becoming aware of that, and then started looking at it, trying to learn more about it, and then COVID actually accelerated that adoption. So people, like, this was never imagined, so that pathologist sitting in the home can report a biopsy. That was never imaginable. So but COVID gave that opportunity, and then digital pathology is now widely accepted. So like radiologists, we also generate images. The slides that we produce are scanned under special equipments called slide scanners. And then the slide scanners convert that entire slide into a digital image. And then on a medical grade monitor, we can zoom in, zoom out, use multiple options to mark areas. So that way it's been very useful. Like it's been my own experience that a radical prostatectomy that used to take 1 hour for me to report, it hardly takes 20 minutes now for me to report, and it's much more accurate. The details stand out. If it were to be a microscope, I have to move different
Correct.
areas, and then so it used to take a lot of time looking very keenly for each findings. But here it's on the screen at one particular zoom. You can look at everything. So that way it has revolutionized the pathology practice.
Right.
Yes, people are now open, and now we
There's
have
better
lot-
technology as well. I
Yes,
think
yes,
there's much amount of evolution with respect to
yes,
technology as well.
yes, yes,
Faster images,
yes,
okay, probably more
Yeah.
amount of zoom
yes.
to better view images has also like transformed our pathologists.
Yeah, now we have another branch of pathology called computational pathology,
Wow.
where you have this AI, ML, machine learning algorithms who are helping,
Incorporated.
yes,
Yeah.
incorporating into the pathology
Right.
practice itself. You have
So-
algorithms which
So
give
does
you
that mean AI can replace a pathologist?
absolutely not.
We do face this clinical scenario when a patient comes in with a biopsy done at an outside hospital. Probably they come to me after 2, 3 weeks. There's always a question posed from the patient that, sir, do you think they would have kept that slide or block in the hospital after the biopsy? How long should an hospital store a biopsy or a pathology lab store a biopsy sample?
So, um, there are no, earlier we didn't have any regulatory guidelines, right? So every lab used to define their own retention period for specimens, slides, blocks. So now we have regulatory guidelines. So we have the National Accreditation Board, which gives a clear-cut guideline that every specimen has to be preserved for 30 days.
30 days.
30 days,
Okay.
1 month.
Specimen means the
Specimen.
whole operated
Yes,
tissue.
whole operated tissue has to be preserved for 30 days.
30 days.
And then the slides and the blocks have to be preserved for 10 years.
10
Okay.
years.
10 years, that was the thing. Now it is revised to 5 years.
5 years.
Yeah, but they say that this is a minimum requirement.
Okay.
So every hospital can define their own, whatever they want to follow, they can define, but this is the minimum requirement.
So why is that
So-
as a practice the slides or blogs are not given off to the patients directly?
It's institutional policies actually. If you go to standalone lab, they just dispose it off to the patient because they don't want that headache of preserving that material. But if you go to the hospitals, they preserve it because they want to, make use of that for the patient's benefit. In the sense, if he comes back tomorrow with some recurrence, you always have a material that you
Correct.
can go back and check. Or if they want to decide on treatment options or change a treatment modality, try to do some other molecular markers or genomic signatures or targeted therapy decisions, then you have a material readily available so that you can do it without wasting much time. And the blocks that we make, they are actually tissues that are molded in paraffin. So they can be preserved as long as you want. You just have to keep it in a cool place. That's all, without much variation in the temperatures. You can just leave it in your cupboard, anywhere. You can just keep it and it stays there and it can be used anytime in the future.
Right.
So, what do you think the next great revolution in pathology is going to be? Is it going to be AI? Because the word right now across the world is artificial intelligence. So, do you think AI is going to revolutionize pathology? And if so, how is it going to revolutionize?
Yeah, there are multiple things that are going to revolutionize pathology, and the baby steps have already started. One is machine learning. So there are a lot of work that's being done, not only from aiding in the diagnosis, but also in the prognostication, identifying the molecular signatures on the unstained slides itself. Thereby the turnaround time, the expenses to the patient, everything is saved. So this is one aspect that's people talk about, and there's a lot of work happening. You have several AI companies now, each one working on different aspects of pathology. It's very exciting and very promising as well. You have another branch that is emerging, and I'm sure that it's going to be one of the strongest branches of pathology, is what is called as therapeutic pathology.
Okay.
This is something what we call as clinical pathology as well, but I think therapeutic pathology will be the better terminology. So the pathologists are going to collate the entire information, the clinical, the radiological, pathological, molecular, everything, and then write a final dictum for the patient. So this is a branch that I feel is also going to pick up, because it does not limit the pathologist only to a microscope or a digital image, but it is a collaboration of everything that they do in correlation with the clinical and the other findings. So that way I can see these two branches coming up in a big way. But artificial intelligence has already made a
Made
place.
up case.
Yeah, but therapeutic pathology is starting. I think that will also be a good. Yeah.
To conclude, ma'am, in your clinical practice over the past 2.5 decades, is there a clinical scenario or a patient who has, made you emotionally, vulnerable, or probably where you feel you have created great impact in concurrence with a clinician? Overwhelmed with your, clinical decision, or where you have created huge impact, or probably you would have had a tear in your eyes? Is there a scenario where you can think of?
Mm, the one example that I gave you, myeloma, that was a really,
Challenging
very
case, and you've
challenging
created.
and very touchy also, because the entire parents came with the son, and they were very emotional, and it was very touchy. So, but finally, when we signed out as benign, they were very happy. I mean, their faces just lit up. So that was very satisfying as a pathologist. Yeah.
So, what is that one advice that you would give to a common man who's going to get operated for some condition somewhere? What is the one advice you would give to your fellow pathologist who may be reporting it from some end? And what change would you make in the education system as an oncopathologist?
Yeah, from a patient's perspective, always better to have an expert, advice and an expert opinion. So, expert advice from a clinical perspective, and then an expert opinion from a pathology perspective. So, every pathologist tries to do everything, but multitasking is not possible. You can do it to some extent, but when it is concerned with the health of a patient, it's always leave it to the experts. So that is what I would say. uh, Accepting our limitation is something that we all have to be aware of, and in the interest of the patient, ego should not come in the place. So if you don't know, say I don't know, I would like to take another opinion. So there's no harm in saying that, right? And so help the patient, send it to your colleague, or take peers or any reputed place, and then take an opinion, and then convey it to the patient. From a patient's point, it's always better to have another opinion if at all they've been diagnosed in a local lab, or so better to take an opinion from a pathologist who is trained. Pathology is not just histopathology, hematology. Now it's beyond. So we have subspecialties. So we have pathologists who report only on breast cancers, pathologists who report on endometrial cancers, brain tumors. So it's much beyond, right? So take opinion from an expert pathologist who practice in a a
Yeah.
well established center, who see these cases day in and out. So that is what I would recommend to the patients, and as well as to the fellow pathologists.
And what about the
Education, coming to the education system, my advice to the students is spend time. So internet will give you only the knowledge, but the practical application comes only when you
Experience and
practically
practice.
practice it.
So when you speak of it, you do have a fellowship in oncopathology.
Yeah.
So that is for students who have finished their pathology.
Yeah.
So
So
how long a course is that, ma'am?
yeah, so we have this course is from the Rajiv Gandhi University of Health Sciences. It is about 18 months course.
One and a
this
half year.
Yes, 1.5 years course, and this is for all post MD, post DNB students, and it's a very extensive course, because our workload is so huge, and then we have everything under the sky that's needed for the oncology diagnosis. So it's a full-fledged course, and they literally get to learn what is necessary for the oncology practice. In addition, we also have observership programs where we encourage
MD.
post MD students to come and just observe what we do, so that they enhance their knowledge, and they also get to learn,
Right.
right? Seeing the slides, and then attending MDTs. they get to learn the clinical correlations, radiology correlations. So these observership programs we have in different organ systems. We have breast observership, we have GI observership programs, we have head and neck observership programs. So these are for 4 months.
Right.
So they can choose whatever organ system they are interested in it, and then they can enroll. And there is, it's very good to attend and make use of all these programs that we have. So rather than after completing MD straight away jumping into the practice,
Right.
it's better to get
That orientation.
orientation, get trained,
That's
get
amazing.
some expertise, and
Yeah,
then
yeah.
start practicing it.
It was very good to have you here, ma'am. A lot of information.
Pleasure.
They may never see the patient, but I think the first cure happens with a pathologist who sees the truth the first. Thanks for coming on the show, ma'am. It's been a pleasure interacting with you.
My pleasure.
Thank
Thank
you
you so
so
much for
Thank
inviting
you.
me. Thank you.